the whole talk is about diabetes and kidney, and heart we have seen. So next we come to kidney, and kidney is important because it directly affects the heart, right? So that's what kidney disease patients are more prone for cardiac events, and most of the patients with any nephropathy, the death cause of death more commonly is heart ailment rather than end stage renal disease. And as a blanket, the KDIGO defines CKD as abnormalities of kidney structure or function present for a minimum period of 3 months. So that makes it chronic with implications for health, and it is classified based on the cause, glomerular filtration rate, and albuminuria. So it is the CGA as abbreviation. So when we come to diabetic kidney disease, it is now divided into classical and non-classical types. Classical diabetic kidney disease comes under the, of course, both come under the chronic category, and in this case there will be gradually increasing urinary albumin excretion, the blood pressure will start increasing, and as the BP and the urinary albumin excretion increases, there is increased risk of cardiovascular events, and there is presence of retinopathy. So retinopathy is present, the EGFR continuously falls, which eventually leads to ESKD in some patients. And when we look at the pathophysiology, we see there is basement membrane thickening, mesangial expansion is there, podocyte alteration or loss can be there. There will be tubular interstitial fibrosis, which will eventually lead to glomerulosclerosis. And when we look at the graph, so the white part of the graph is actually the normal range for each of these: albumin excretion, blood pressure, and glomerular filtration. And in classical DKD, the glomerular filtration will continuously keep on coming down, albumin excretion will continuously increase, and so will be the blood pressure. Coming to the non-classical DKD, now this is seen in about 7 to 22% of type 1 patients, but almost half the patients with type 2 diabetes have non-classical DKD. Here the progression of this chronic kidney disease is comparatively slower. There is no preceding albuminuria, there is absence of retinopathy, and on histology you will see that there is arteriosclerosis rather than atherosclerosis, which is seen in diabetic kidney disease. And the underlying process is a combination of aging, hypertension, atherosclerotic vascular disease, diabetes, obesity, ectopic lipid deposition in the kidneys, and pathophysiology is arteriosclerosis. And you can see, compared to the classical DKD, this is a little milder one, which progresses slower, and again here the blood pressure continuously increases, but the urine albumin is mostly under the normal albuminic range, and with time here also the GFR starts reducing. Coming to any patient who has diabetes, be it type 2 or type 1, they need to be screened regularly for their kidney disease. Of course, it doesn't mean they should not be screened for anything else, but I'm going to talk about kidneys right now. So in type 2 patients, at the time of diagnosis itself, they should be screened for all the micro and macrovascular complications, but this screening starts only after 5 years in type 1, and it should be done annually thereafter or earlier if there is any abnormality. What do we look at? Of course, we look for albumin excretion rate. Now this albumin excretion can increase in conditions of hyperglycemia, when blood sugars are uncontrolled, with uncontrolled hypertension, and when the patient has maintained an erect posture for a long time, again albumin excretion increases after strenuous exercise, in presence of any urinary tract infection or infections, when a patient takes a high protein diet or certain drugs. So these can increase the albumin excretion rate. What else can we look for is ACR, PCR, albumin creatinine ratio or protein creatinine ratio, and the creatinine, serum creatinine has to be seen, and based on that we have to see the EGFR, and EGFR usually we use the CKD-EPI equation, which uses the creatinine, age, sex and ethnicity for calculating the estimated GFR in the patient. And final screening status should indicate both the GFR and urine albumin excretion status. So this is KDIGO, CKD, EGFR for, and here we can, this helps, this heat chart, it helps in prognostication of diabetic kidney disease or any chronic kidney disease. And here the GFR is divided into G1, 2, 3A, 3B, 4 and 5 depending on the GFR rate. So more than 90 is normal and less than 15 is kidney failure, and we have ranges in between. Same way, proteinuria is divided into albuminuria is divided into A1, A2, A3. A1 being normal, where it is less than 30 milligram per gram of albumin excretion, and A3 is severely increased, where it is more than 300 milligram per gram or 30 milligram per millimole of albumin excretion. EGFR, normally what happens to the EGFR is normally there is a reduction of 1 ml per minute per 1.73 meter square per year in all the individuals. So each one of us, as we age, slowly there is around little less than 1 ml. So maybe every 2 years it will reduce by 1 ml. This annual decline of EGFR will be around 1.5% in non-albuminic patients with diabetes, mild albuminuria. So patients with mild albuminuria will have an annual decline of 1.5%. Those with moderate albuminuria will have an annual decline of 2.2% of EGFR. Now, in severe albuminuria, the decline is much more. It is around 10 to 12 ml per minute per year. And if we don't treat these patients, if this albuminuria is treated with adequate blood pressure control and glycemic control, the decline will reduce from 10 to 3 to 5 ml per minute. So this is the important part we should remember, that treatment of blood pressure and glycemia plays a very important role in reducing the fall in EGFR. So what are the risk factors for diabetic kidney disease? Family history, very important. So genetics plays a role. Ethnicity, so Asians are more prone, Afro-Americans are more prone, Caucasian races. Duration of diabetes is the one most important factor, which is the risk factor for DKD. Then poor glycemic control, uncontrolled hypertension, dyslipidemia, periodontitis, MASLD, all are associated risk factors. Smoking is an important risk factor, obstructive sleep apnea. Albuminuria due to any other cause again is a risk factor for a person with diabetes. Hyperfiltration, preeclampsia, inflammatory markers, and urinary tract infection. Now, when we have diabetic kidney disease, it is a microvascular complication. So what happens to the other blood vessels? So what about the other macrovascular complications? So we can divide into type 1 and type 2. In type 1 patients, when there is moderate albuminuria, there is 2 to 3-fold higher risk for premature mortality and 1.2-fold higher risk for cardiovascular disease. With severe albuminuria, the risk of premature mortality increases by 9-fold and risk of CVD and stroke increases by 10-fold. In patients with end-stage kidney disease, premature mortality increases to 18-fold. And in type 2 diabetes, there is 2 to 4-fold CVD risk with moderate albuminuria and 9-fold with severe albuminuria. Coming to the microvascular complications, in type 1 patients with moderate albuminuria, retinopathy is almost always present. Whereas in type 2, the classical nephropathy have significant retinopathy. Classical nephropathy patients will have significant retinopathy, and retinopathy usually is absent in non-classical type. Peripheral neuropathy is also common in patients who have already developed DKD, and autonomic neuropathy, because there will be a loss of nocturnal dipping of blood pressure, which is frequent, and it predicts a decline in kidney function. So that's why the role of 24 hours blood pressure monitoring is very important, so that we can predict a decline in kidney function if there is lack of nocturnal dipping. So now we have to do, other than monitoring, we should investigate a patient. So we should look for the glycemic status by the blood sugar values and HbA1c. Urea, creatinine, electrolytes and uric acid should be estimated. Lipid profile to be seen. Just now Balamurugan was saying, so the lipids LDL should be targeted to below 70. Urine albumin excretion or albumin creatinine ratio, urine culture sensitivity, CBC, vitamin D. So all these other tests are done to rule out any other cause of kidney disease or to rule out the acute or chronic kidney disease consequences. Because the bone metabolism is affected, we need to see vitamin D and calcium levels. Ultrasound abdomen is essential to rule out any secondary cause and see the kidneys and other organs. BP monitoring, ECG, echocardiogram, fundus examination, NT-proBNP, autoantibodies, immunoglobulins to rule out any other cause, ASO titers, and if we are not sure of the diagnosis of CKD, we can always go for renal biopsy if it is not very late. Next, we come to the management. Management are divided into prevention and the management of CKD. So, prevention of kidney disease, or if it has already set in, to reduce the progression. So, to delay the progression of disease, we need to go for lifestyle modification in form of diet, exercise, and decreasing the stress and cessation of smoking, adequate sleep. Glycemic control plays an important role where we have to monitor the self-monitoring of blood glucose should be taught to the patient, because people with established diabetic kidney disease, the hemoglobin comes down, the proteinuria is there, so both HbA1c and the fructosamine are not reliable monitoring ways for glycemic control. So SMBG is more superior. We can also go for continuous glucose monitoring where the patients have recurrent hypos. And then the various glucose lowering agents we can use. So for the kidney disease, we can use SGLT2 inhibitors, metformin. After the EGFR has gone below 45, we have to reduce the dose. Once it is less than 30, we can stop metformin. And we should use not the first generation sulfonylureas, rather the shorter acting sulfonylureas like glyphosate or glycoside. Then we can use when the EGFR is reducing based on the EGFR, we can use the DPP4 inhibitors. But again, DPP4 inhibitors among the various ones, both Rina and teneligliptin dose need not be changed, but other drugs need a reduction in dose according to the EGFR. Then BP control is by AC inhibitors or ARBs. Proper hydration should be maintained, and dyslipidemia management with statins and not fibrates, because fibrates they may increase the creatinine, though there may be reduction in they may help in reducing the cholesterol levels, they may cause an increase in creatinine. Now this is usually in the stages 1 and 2, we can go this with this regular one. But when the patient goes into stage 3 to 5, we have to now look at the protein intake. So protein intake should not be less than 0.7. So it should be at least 0.8 gram per kg body weight per day. And patients who are put on peritoneal dialysis, they need 1 to 1.2 grams per kg of ideal body weight of protein. Salt restriction should be less than 5 gram per day or sodium less than 2 gram. And how we tell it is a spoon, a teaspoonful, and you flatten the spoon. So that will be 5 grams. Weight management, then RAS blockade, SGLT2 inhibitors, GLP-1 receptor agonists, CV risk management with the help of smoking cessation, statins, and aspirin. And because these are high-risk patients, high risk for coronary artery disease, stroke, so aspirin is indicated in patients with diabetic kidney disease. Mineralocorticoid receptor agonists, especially the finerenone, has come in a big way in reducing the in reducing the albuminuria. But again, we have to monitor the potassium levels. Then we have endothelin receptor antagonists, and this class of drug, though they have shown some reduction in albuminuria, there is not much effect on CV benefits. Then iron supplementation, erythropoietin, calcium and vitamin D supplementation are other supportive. So once you have diagnosed the patients with DKD and you have put them in, staged them, then we have to look at the ACR every 3 months. So monitoring is essential to see how much our therapy is working for them. So if the drugs are working, or is the patient having any other issues. So we have to look for album creatinine ratio every 3 months, EGFR calculation, that is creatinine every 3 to 6 months, regular BP monitoring, so it should be done at every office visit, HbA1c every 3rd month, fundus examination according to the ophthalmologist's guidance. We should advise the patient for fundus examination. Lipids can be done 6 months or annually, and ECG. Patient, because these patients may develop silent MI, they develop neuropathy, autonomic neuropathy, so ECG also can be taken if you have any doubt, or at least annually. What are the treatment targets? We have to target a BP of less than 130 by 80 millimeters mercury. LDL cholesterol should be below 70 milligrams, and HbA1c less than 7%. And then this becomes individualized depending on the patient's age, the stage, and we cannot give very tight control because more hypoglycemia is common because insulin is cleared through kidneys also. So the insulin will stay for a longer period in the blood. So hence HbA1c cannot be strictly followed, but we have to see the patients. And this, next comes the albuminuria. So we should try to reduce the urine albumin creatinine ratio by 30% at least. So the reduction should be by around 30%. And frequent EGFR monitoring 2 to 4 times per year if CKD stage is more than 2. Now very important, how long shall we treat the patient and when do we need to refer the patient to the nephrologist? So first and foremost is when there is diagnostic uncertainty. We are not sure if it is diabetic kidney disease or some other cause of kidney disease, or we suspect there is some other cause of kidney disease, then better is a nephrologist take care because they will need renal biopsy. Then when the BP control becomes difficult, so I was already telling resistant hypertension is common in nephropathy patients. Then wherever there is fluid overload, anemia which is unresponsive to oral iron therapy, abnormal bone chemistry, EGFR has gone below 30. Right? So EGFR less than 45 itself, we can refer the patients to nephrology. Then if the EGFR fall is more than 5 ml per year, so normally we don't expect. So if the fall is faster, then we need to refer to a nephrologist. And in any patient who has developed nephrotic syndrome, they have to be treated by the nephrologist. So coming to the last part of the slide, final takeaways. So what all was talked here, it is a comprehensive reference for evidence-based practice. Right? So finally, you are the masters. You are going to decide because the patient is your patient, and based on their problems, you have to decide the various treatment modalities. And the management also is quite dynamic and evolving. So staging, when there is acute or chronic kidney disease, the creatinine will be on the higher side. So EGFR will be far lower. So once you treat the acute disease, the creatinine will start reducing, EGFR will improve, and then the management will change. At higher stages or categories of CKD, it portends greater relative risk for adverse outcomes. So we have to be much more clear about the management strategy we are taking for these patients, and we have to monitor them more thoroughly. And we should always rule out other causes of CKD, regular monitoring, fundus examination, these are a must. And very, very important part is we have to empower the people with diabetes with proper education about complications, diet, exercise, medications, and follow. With this, I would like to thank each one of you.